Thank you, Greg. Now I'd like to welcome to the stage Dr. Miriam Bredella. She is Bernard and Irene Schwartz Professor of Radiology at NYU Grossman School of Medicine and the Director of the NYU Clinical and Translational Science Institute.
Okay, so thanks so much for inviting me, and I'm really excited to talk about AI and imaging. So I'm a radiologist, as Liz said, so that's why I focus my talk on meta-research in imaging. So why do we need AI in imaging? Well, we want to prevent diagnostic errors. We have an extremely high workload, so AI can help us with this, maybe. I don't know, can you guys hear me okay? Our cases are getting more and more complex, and there are time constraints, so AI might make us more efficient. So that brings me to the next question. Why do we need meta-research in imaging AI? So as I just showed you, AI in imaging is really exploding, but rigor and transparency vary wildly. And so we really need meta-research to improve the transparency and reproducibility of AI algorithms. We want to reduce bias and systematic errors and aid in the responsible implementation. And once we implemented our AI algorithm, we have to make sure that they perform adequately, and it requires continuous evaluation. So meta-research really will help us to identify blind spots and help shift from the hype to a reliable clinical impact. So in order to create AI models that generalize well to new data, we need to split our data set when we develop an AI algorithm into a training set, a validation set, and a test set. And that is really to avoid evaluating the model on the same data where it's been trained on, and then also it avoids overfitting. And overfitting means that a model performs exceptionally well on the data it has been trained on, but does not really do well on a new data set. And the splitting of the data will also simulate real-world performance. So the largest data set is the training set, and that's used, as the name said, to train the model, allows it to learn patterns and relationships by adjusting its parameters. And the training data set must be large enough to capture variability in the data, but not so large that the model overfits the training set. So you typically split the training validation tests into 60-20-20 or 80-10-10% of your data. The validation set is used during the training process to fine-tune the model's parameters and to check for overfitting. And the test set is a set that's a holdout set that's kept completely separate until the very end. And that provides really an unbiased evaluation of the model's ability to generalize to new or unseen data. And it's best practice after you develop your model and tested it to then test it again in a completely new environment, maybe in data from a different institution. So bias may arise during any of these stages of algorithm development. And then depending on where it arises, it can propagate systematically through subsequent phases. For example, it starts with a training data set selection in the annotation, model development, evaluation, and then deployment. So I would like to draw your attention to a couple of really severe biases that you should be aware of. And then if you do AI research, or maybe even if you're just a consumer, not a developer, that you know what to ask for. So bias in the data set collection and preparation can really significantly affect the outcomes and can lead to disparities in the performance of AI systems across different patient groups. And one of the primary sources of bias is demographic imbalance. For example, if a data set predominantly consists of images from a particular racial or ethnic group, the AI model trained on this data set may be less accurate in individuals from other groups, and that can lead to misdiagnosis or delayed diagnosis for the underrepresented groups. So on the left, you see optimal representation of your training set. There's demographic balance. You see this is in relation to sex. You have in your training set half women, half men. And if you look at the ROC curves, the model performs equally well in men and women. On the right, you see a poor representation. So you see the model was trained primarily on men. And so it performs very well in men, but poorer in women. And that you can extrapolate it to other areas. Another critical aspect is the quality and source of the medical images. bias can be introduced if the images come from a very limited number of institutions or geographic locations, as different places may use different imaging protocol or equipment, and that can contribute to covariate shift, which refers to distributional differences of features between the training and test set. And these variations can also cause the AI SIPs to become overfitted on the data they've been trained on and to the characteristics that are very specific to the particular institution. And that reduces, again, the generalizability and effectiveness. The graphic here on the left shows distributional differences between the training and test set leading to poor performance, i.e. poor generalizability, or significant deviation from the learned function. You see in the right graphic, the training set, the learned function correlates extremely well, but then you put in a different test set and it's all over the place. Identifying sources of bias in AI requires evaluation beyond the actual images, but also its metadata. So meta here comes. And here's an example how discrepancies in the DICOM metadata and labeling can contribute to bias. The DICOM is a very specific terminology. It stands for Digital Imaging and Communications in Medicine. It's an international standard for storage, management, and transmission of medical images and information and related data. So every image we see also has a DICOM file where there is a lot of metadata. And this is an example where a mammogram, which you see in the middle is a regular mammogram, was in the metadata incorrectly identified as tomosynthesis. The image in the middle shows you the marker, the RMLO, that means the right side is image, and MLO is the projection. Mediolateral obliquity. Then you see the report on the right, where now the radiologist incorrectly dictated the technique as CC, which is a cradiocaudal view, so the view is wrong. And then also in the impression, then, although the right says it in the technique, the impression says the left breast. So all these errors can then cause to inconsistency, and that's particular if you develop AI models that integrate both imaging and text data. So it's really important to make sure that you are correct in the DICOM metadata. This is something I think is extremely fascinating, that actually AI models can learn to identify confounding features, which then can lead to unfair predictions. So, and these confounding features include laterality markers, which are image annutations you see here that indicate the side of the body, whether it's right or left. And actually AI algorithm can be trained or learn themselves to identify the hospital at which place this chest X-ray was performed. And the image on the right, which is an X-ray of the wrist, was from a study that showed used AI to train abnormalities on bone radiographs. And in this study, they found that the AI models often focus on the laterality or the technologist's initials, which are typically done for every X-rays. And then they made predictions based on this rather than looking at the images. So maybe they say this technologist always works in the ER and there are more fractures, so this patient is more likely to have a fracture just based on the laterality and the technologist marker, but not actually looking at the images. And there were several studies that have focused on this. And many of these biases can be obvious, like the wrong side, right or left, or the view, but a lot of them can actually be very salient. And studies have shown that imaging AI models can predict demographic information from images without clear explainability. And for example, an AI algorithm can predict which race a patient is from just looking at an X-ray of the hand, gender or age, although the model has never been trained on those tasks. And what is really interesting is that these AI models that are most accurate in making these demographic predictions also show the biggest, what we call fairness gap. That is the discrepancy in the ability to accurately diagnose images of people from different races or genders. And what these models are doing, they're doing demographic shortcuts when making their diagnosis. That means the AI model uses the demographic, race, age, ethnicity to make the diagnosis, and determine whether someone has maybe diabetes or heart disease, rather than actually looking at the imaging features. And this can lead to incorrect results for typically underrepresented groups and potentially exacerbate disparities. So AI algorithm can actually make the right diagnosis for the wrong reasons. Once the model is deployed, it requires assessment of how it performs in real-world scenarios. And concept drift is also a source of bias, which arises when the correlation between your input variable, which is our images, and the output prediction, which is the diagnosis, evolves because there are fluctuations in data. So for example, if there are variation in image acquisition, you buy a new scanner, or you introduce a new protocol, like an imaging protocol, maybe low dose imaging, or shift in the disease prevalence, or changes in the reference standard for a society comes out with new guidelines. And this can all then change your model. Here is a simplified graphic of the true concept drift showing that adding new data over time changes the relationship between your input features and the diagnosis, which ultimately changes your model's behavior. So here are some recommendations for fair and accurate AI in imaging. So first, you should really determine the clinical problems involving all stakeholders together and make sure there are no disparities. Or if you know them, make sure you address them. When you curate your data set, you have to do some comparative analysis or explorative analysis, compare distribution to the target distribution, see whether there are any demographic imbalances. For data annotation, this should be really standardized, and you have to have a process to address any disagreements in the labeling. For model training or testing, again, you need to split your data to avoid overfitting. You have to have some appropriate metrics on your performance, and you have to incorporate model explainability and uncertainty quantification test techniques, and always make sure it behaves adequately in all subgroups. And then once you deploy it, you have to continuously monitor the performance. So journal editors started this checklist for artificial intelligence in medical imaging, or CLAIM, which is an editorial policy which really aimed to increase reproducibility and generalizability of results. It's similar to the STROBE or START guidelines. It's really a best practice in AI imaging, and it's really there to for transparency of algorithm and code. And this checklist also requires or requests that the code should be shared in a publicly accessible repository, for example, GitHub. This is just an example of the list. Just want to highlight data. So it really very carefully goes through how did you pre-process your data, how were the subsets selected, de-identified missing, how do you handle missing data, and so on. And for the results, what are the number of patients included and excluded, what are demographic clinical characteristics, performance metrics, and so on. However, this is just from a study that came out last month that showed that only 40% of radiology AI studies share their model, and the deep learning models showed the lowest availability, about 11.5%. Additional studies showed that journals actually rarely mandate the AI-specific checklist, and only a little bit of 30% of AI papers share any code, 11% provide reproducible code, and data sharing is very rare. Only 13% share data and code, and 2% share any data, and 2% only code and data. External validation sets are often missing, which can lead to overfitting and bias. Barriers are IP, privacy, technical efforts. Some people just don't want to share their results. And prospective randomized controlled trials in AI are very few and mostly single center. The consequences is slow progress and irreproducible claims. So what can we do? If you're a researcher, adopt the CLAIM guidelines, share your codes and models. If you're a journal editor, mandate the checklist and model availability. Funders, regulators should incentivize reproducibility in open repositories. Clinicians, if you implement an AI model, demand an external validation before use. Ask them, how was this model trained? What kind of populations? And meta research will be there as a quality control mechanism, and it really requires collaboration between clinicians, developers, and regulators. Thank you very much.